Welcome back, everybody. We will be starting with Q&A, question and answer round shortly. We have got plenty of really interesting questions, and I can't wait to ask our experts some of these questions. So as soon as Dr. Mehr and Dr. Liu flash up on our screens, I can begin the Q&A rounds. Seems like we have Dr. Mehr with us. I would request Dr. Liu to switch on his camera and microphones. Oh, fantastic. Awesome. We have all the smart people in the room here now. Great. Sounds good. So we have gotten a lot of questions. Let me see. I'm going to read out the first question. It's more of a clinical scenario. So I guess this would be an apt question for Dr. Liu. So I'll start with him. This question from a patient. I was diagnosed in 2016 and had a total abdominal hysterectomy and bilateral salpingo-oophorectomy and removal of adnexal mass. Omentectomy, small bowel resection, primary reanastomosis. Started octreotide and did pretty well for about 3 years. However, in May 2019, started having some pelvic pain and left upper quadrant pain. CT scan unfortunately showed an obstruction at that point in time. Surgeon found several tumors in small bowel this time, some large bowel involvement as well. I have not recovered as well after this last surgery and continues to get some pelvic and left upper quadrant pain. I recently had Prrt in May 2020. How often and what type of CT or PET should I get to keep an eye on the disease status? Actually, this question might be good for Dr. Mehr as well. So chime in, please.
Yeah, so let me just make one. Oh, go ahead, Sam.
No, please.
I just want to say one thing about this. So this is not a great forum in order to go over individual cases. So if the audience has individual questions, I wouldn't post it here. And the reason I say that is because a lot of people want me to practice internet medicine, which is very difficult. I would need to study your case very carefully and kind of figure all these things out before giving any advice. So anything that we're going to talk about today is going to be a little bit generic. So with all that information, which is certainly complicated, it would not be right or do you justice.
That's what I was going to say.
Perfect. So how about let's modify this question and ask a generic question. How often in your practice you like to monitor with the help of scans, and what type of scans, MRI, CTs, or a PET scan, or what type of PET scans, and how frequently?
In our practice, if the patient is doing well, feels well, has normal laboratory findings, we don't scan on a routine basis. We will scan at the end of 1 year following therapy to determine what we call the total body tumor burden has changed since before treatment. It gives us a baseline following treatment. We had a baseline before treatment. This will give us a baseline following treatment. So if the patient is doing well clinically and by conventional laboratory tests, we don't scan on a regular basis except for that 1 year scan.
Thanks, Dr. Mehr. And what about post-surgical cases, Dr. Liu? We might have lost Dr. Liu. Let's try to get back Dr. Liu. If our technical team can help us. While we are trying to get Dr. Liu back, I have a follow-up question for Dr. Mehr regarding PRRT. One of our patients asked, neuroendocrine tumors often employ PRRT, but has it been used for other cancers, especially lung cancer?
The answer to your question is yes. The reason that PRRT works in neuroendocrine tumors is because they express somatostatin receptors in a certain biochemical environment. Other tumors also express somatostatin receptors. We evaluate with dotatate scans most tumors whose pathologic report says that they have neuroendocrine features. Now, we don't treat all of those patients because even though a tumor may express somatostatin receptors, doesn't mean it will necessarily be a good candidate for Lutathera. But there is one exception. We've had a lot of success treating a certain type of cancer that's a neuroblastoma of the paranasal sinus. And in our experience and in the experience of others who have similarly treated this type of tumor, it works very well. But there are a lot of tumors that have somatostatin receptor expression. Certain lung cancers, certain melanomas, certain prostate cancers. However, even though they express somatostatin receptors, they may not be a good candidate for Lutathera. And the one that comes to mind is prostate cancer, where we see a lot of prostate cancer path reports that say neuroendocrine. And when we dive a little bit deeper in there, we see that there's not really enough expression for treatment.
Right. Thank you, Dr. Mehr. And I completely concur with you. In fact, I had an opportunity to treat esthesioneuroblastoma recently with Lutathera, who had a very PET positive scan. And in past, we've also treated metastatic meningioma, which also tend to express high density of somatostatin receptors. And there are a lot of clinical trials looking into high-grade neuroendocrine cancers and utility of peptide receptor radiotherapy in this arena. So definitely, I agree with you there. We have Dr. Liu back, and we have a very apt question for Dr. Liu. Are neuroendocrine tumor patients ever candidates for liver transplant?
Yeah, the answer is generally no. Because most of the time they have disease elsewhere. They have disease maybe in the bone or someplace else. So according to the most kind of classical rules for transplant, and there are very, very strict rules for this, the answer is no. However, there are some cases in which people have been transplanted and they can actually do quite well. So maybe in the future there will be some role for transplant, but it's not routine today.
Yes, I think that's, I agree with you, Dr. Liu. I think there is a significant lack of randomized data in that space. So we have to await more data. Thank you so much for that. Dr. Mehr, there's a question for you. You'll have to probably put your radiology hat on maybe for this one. Can neuroendocrine tumors in liver be dismissed as fatty liver or liver lesions like cysts?
The answer to the question is yes. Anatomic imaging for liver lesions is generally non-specific. That means that we can see them, but we don't necessarily know what they are. And we try to increase the specificity or being able to narrow down what they are by doing special types of CT scans, doing special types of MRI scans, using liver-specific MRI contrast agents. However, neuroendocrine tumors, and Dr. Liu, please tell me if you disagree, can exist in the walls of a common cyst. So it's a cyst, but it's also a neuroendocrine tumor.
Absolutely.
Perfect. My next question is to Dr. Liu. And being a neuroendocrine tumor specialist, I think he'll be able to answer this question. I'm combining 2 or 3 similar themed questions. Are all NET specialists oncologists? And what's the best way to find a NET specialist?
Well, let me start with this. The oncologists are the worst neuroendocrine specialists. I'm kidding. That was for Dr. Chauhan. That was for unless he cures high-grade neuroendocrine carcinoma, then he will get credit for that. So the answer to your question is they can be actually lots of different people. I mean, in theory, I would hope it'd be someone who sees a lot of high-volume neuroendocrine. So I'm a surgeon, but I take care of people. I don't just do surgery. I take care of all their needs essentially, but I'm a little bit unusual. Dr. Chauhan, who's a young medical oncologist, works under the tutelage of a, grandfather of our disease, Lowell Anthony. But it doesn't really matter. It really just depends on who understands the disease very well and has built the system around them. So, Dr. Mehr is obviously nuclear medicine, but there are endocrinologists like at the University of Iowa. There are gastroenterologists like at the University of Pennsylvania. There are, other people who are just very interested in it. And the real grandfather of our field is actually Dr. Richard Warner, and he was a gastroenterologist all those years. So the most important thing is you see someone who really, really understands the disease. And that can be tricky because, despite the fact that say, go see a NET specialist, I mean, the question is, what is a NET specialist? That's complicated.
Correct. Thank you so much. Dr. Liu, I have another question for you. One of our patients asking if the carcinoid syndrome symptoms are not resolved with the maximum dose of, in this particular case, somatulin. And in this particular case, the patient's using somatulin every 14 days. What do you do?
Yeah, that's very difficult and complicated. And the question is, what is going on? So, somatulin, everyone knows, is the drug lanreotide. And it's a somatostatin analog, which usually suppresses the hormones. But again, this is one of those cases in which I can't just answer, we can't do internet medicine. I have to study the case. How much tumor do you have? What's being secreted? What are the different symptoms? Do you really have carcinoid syndrome? Sometimes you can add a medication called telotrestat, Zermelo, like I had mentioned previously. And if you want to learn more about it, I think they have a booth in the lobby. But those are the kinds of things that we have to study carefully because I just don't really know what's going on.
Gotcha. Yes, very fair. What do you do for appendiceal neuroendocrine tumor about 2.3 centimeters and spread to one lymph node? What are the current guidelines and what is your personal preference?
Well, that's a really interesting question. So in general, the party line is any appendiceal tumor that's a little bit greater, that's greater than 2 centimeters, requires a partial colon resection so we can take a look at the lymph nodes. If you've already had that operation and there was just one lymph node, you're probably in pretty good shape. Luckily, the 25-year survival of appendiceal neuroendocrine tumors is essentially 100%. But there's some variations to it. And so we have to kind of understand and figure those things out. But if you've already had that other operation, you're probably in pretty good shape and just need some surveillance.
Thank you. Dr. Mehr, next question is to you. If lysine and arginine are used to protect the kidneys during PRT, why don't we take these as daily supplements?
It's a little bit more complicated than that. The electrical charge on those two molecules prevents the similarly charged dotatate molecules from accumulating in renal tubules. I apologize for getting so technical, but it's not for general kidney health. It's to prevent the accumulation of a specific molecule. And if that molecule isn't present, then the drugs have no benefit. I don't know if I've explained that properly or not, but that's the answer.
I can actually add one tiny little thing to that. Arginine and lysine are actually very good for wound healing. So I actually give those two for surgery.
Oh, wow.
Yeah.
This is something I learned. Awesome. Great.
Yeah. Thank you.
Dr. Liu, that next question is to you. What are adhesions, which you mentioned before in your talk, and after surgery of ileum, how do you manage them, etc.?
Yeah. So the question really is, what happens when you take out a piece of intestine that's very important? People kind of underestimate how important the intestines are and how different they are. Like Dr. Mehr just said, getting to the weeds can be a little bit difficult. However, the classic place for a lot of neuroendocrine tumors to come is from what's called the terminal ileum, which is the very, very end of the small intestine, just as it enters into the colon. And there's a little valve there called the ileocecal valve. Most people actually do fine. They may have a little diarrhea afterwards, but they usually do great. But they can have some problems. They can have some adhesion problems just from any kind of an operation. They can have absorption problems, like the bile can kind of flow out too fast and give you chronic diarrhea. People can have some vitamin reabsorption problems. But in general, it's very, very well tolerated. But what people really, if you're going to have a problem, it's usually from chronic diarrhea.
Fantastic. Thank you. Dr. Mehr, during PRRT treatment, does the patient continue Octreotide and Affinitor?
Well, not Affinitor. That's not a suppressive agent. That's a completely different ballpark. But if they're on Octreotide or Lanreotide, the two suppression drugs, they absolutely continue it during therapy. And they continue to take it on a regular basis. And there's some good literature that demonstrates that prolonged use of these suppression drugs during and beyond therapy really increases the effectiveness of the PRRT treatment.
Perfect. Thank you. I have a follow-up question, Dr. Mehr, and this is more patient-specified, so I'll try to rephrase it to make it a more generalized question. So, does Lutathera work in bone mets, and how many doses would you give before you think that the treatment's not working? And lastly, would you consider adding capecitabine temozolomide to Lutathera? That was a loaded question, so sorry about that.
Okay. Does it work in bone mets? In my experience, yes. As a matter of fact, in certain patients that have metastases to the outer portion of the bone, the portion of the bone that we call the cortex, it works so well that the dying cells create an inflammatory response within the adjacent bone that actually causes a transient increase in pain. So in cortical bone, or the portion of the bone that's structural, in my experience and in the literature, it does work. Now, capecitabine, that's a common chemo combination for neuroendocrine tumors. It's abbreviated as CAP-TEM, and that's not given as part of PRRT, but can be given in a separate route or a separate pathway for therapy.
Thank you so much, Dr. Mehr. And just to add a slight comment to that, there was a recent clinical trial which looked at adding CAP-TEM as a radiation sensitizer to Lutathera. And unfortunately, at least the interim analysis did not show any significant benefit. In fact, there was a trend towards higher toxicity by adding it. So it is certainly not a standard approach to add the cytotoxic agents along with Lutathera at present. Thank you for that.
Right. And just to expand, if I may, one of the future, a current research pathway in PRRT is combination therapy, or using PRRT as adjuvant therapy or something called neoadjuvant therapy. But it's combination therapy. And that is a very robust area of research. And I expect that in the very near future, we're going to see lots of alternatives in PRRT that involve combinations with other anti-cancer drugs.
Absolutely. Thank you so much. Dr. Liu, next questions to you. Can PNETs be functional, or can the pancreatic neuroendocrine tumor present with a syndrome?
Yeah, so that's an interesting question. So when we say a neuroendocrine tumor is functional, what that really means is it secretes some kind of a hormone which causes people to have a bunch of symptoms from the hormone. Okay, so a lot of neuroendocrine tumors from the pancreas actually are not functional. Probably about 50 to 70% of them are not functional. Now, they may produce some hormone that we don't measure regularly and may not cause some particular symptoms. So there's a little bit of, subtlety there. But a lot of them present with pain. A lot of them present with blockage of blood vessels. A lot of them present incidentally. And so those are kind of the very careful things you have to tease out. So I don't really differentiate functional versus non-functional anymore. It really just depends on how it affects the patient and what their surgery is or their PRT or whatever the treatment is going to be. But a lot of people can have symptoms from it. And you can have symptoms from a teeny tiny little tumor. It can be like 5 millimeters and you can still be symptomatic from it.
Gotcha. Just a quick follow-up question, Dr. Liu. Thank you for that. Can they specifically have carcinoid syndrome as well?
Oh, sorry. Thank you. So the carcinoid syndrome is classically, it's not 100% true, but it's classically overproduction of serotonin from small intestinal neuroendocrine tumors that get to the liver. That's what it classically is. And it usually presents as what's called flushing and diarrhea. So you get all red and you have a lot of diarrhea. In general, that does not happen with pancreatic neuroendocrine tumors. Usually the diarrhea comes from things like gastrin or VIP or some other hormone. However, there are serotonin-producing pancreatic neuroendocrine tumors, which are actually very interesting. They're very scarred down and sclerotic. They're not that common, but the symptoms can sometimes overlap with the carcinoid syndrome. So, whatever is affecting you is affecting you, and a lot of times the treatments are the same. So I just kind of clump them all together.
Fair enough. Thank you so much. Dr. Mehr, next questions to you. Have you ever encountered neuroendocrine metastases in eye, and how would you evaluate it? Especially what imaging modality? Would it be an MRI, or can gallium scan pick up a small met in the ocular cavity?
There are reports of neuroendocrine metastasis to the eye. There are reports of neuroendocrine metastasis to the linings of the brain and linings of the spinal cord. The areas that would be difficult to evaluate with imaging are areas that are adjacent to sites of normal accumulation of the diagnostic radiopharmaceutical. For example, a very small abnormality on the adrenal gland may be difficult to see because the adrenals normally accumulate the tracer. The same thing for the spleen. But sometimes direct visualization and dedicated imaging of the area where you expect to find the tumor could be indicated. For example, if we suspected that there was a neuroendocrine tumor near the eye, rather than doing, or in addition to doing, the conventional skull base to mid-thigh PET CT scan, we would do additional dedicated imaging of the head. So every patient is different. Every patient presents a different challenge, and every diagnostic and therapeutic regimen requires individualization for those patients.
Thank you so much.
Hey, Aman, can I make a comment on this? So metastases to the eye are relatively rare. Can you guys hear me okay? Sam,
yeah.
Can you hear? Okay.
Yep.
So metastases to the eye are relatively rare. And however, it doesn't usually go to the eye. The place where it really goes is actually to the muscle next to the eye that moves the eye. In general, the lesion tends to be asymptomatic when they're very small. But when they get to be larger, we will actually remove them with surgery. But you need to get it in kind of the right spot, essentially. And then you can also treat them with kind of radiation therapies. And of course, the PRT is always an option as well, too. But the great thing is that the gallium dotatate scan has actually shown us these lesions, which usually missed on the usual scans we check of the body. So as Dr. Mehr just said, we would get this dedicated, an MRI of the orbit essentially is the best scan to see these things. But if you have that and they progress, that's something where you should probably see a really dedicated neuroendocrine specialist, because we take care of these things.
And this is in support of what Dr. Liu has been saying all day about the importance of surgery. Neuroendocrine tumors are different than most tumors because the size of the tumor doesn't necessarily relate to how severe it is. You could have a huge golf ball sized tumor in your mesentery that's causing no problems. Or you can have a tumor the size of a head of a pin that's wreaking havoc with your body. And because of that, nothing can replace actually looking at the tissue, which is what Dr. Liu does.
Great. Thank you, guys. My next question is Dr. Liu. Do you generally recommend getting a second opinion on your pathology, especially post-op? Dr. Liu, I think we lost your audio. Can you hear us? Oh, I think we're going to try to get Dr. Liu back. And I have a question for Dr. Mehr in meantime. How often do you see bowel obstructions after PRRT? And what do you do?
Well, I've never seen it. And that's because when we see tumors that are in the bowel, we understand that if we give PRRT to a tumor in the bowel, there will be something called pseudoprogression. In other words, the tumor will likely get bigger. And the reason that it gets bigger is because as those tumor cells die off, there is swelling created. And that swelling can enlarge the tumor. And for that reason, if we see tumors that, if they got bigger through pseudoprogression or swelling, it would be best to have them surgically removed before you give the PRRT. And that, again, is a reason to have surgical intervention before the PRRT is given. Did you hear what I said, Eric? Do you agree?
Yes, 100%. In fact, there have been some reports of people who developed small bowel obstruction because they didn't have surgery beforehand.
Right.
So that's some of the complication. But again, someone should evaluate that who's an expert.
Fantastic. Dr. Liu, before I lost you last time.
Sorry.
No, it's all good. Even Steve Jobs used to have these glitches. I think we are doing pretty good. Do you often refer your, for a second opinion regarding your path sample, especially post-op? Do you often go for a second opinion for your surgical sample sent off to a different pathologist?
No, I don't do that because my pathologists see hundreds and hundreds of samples a year. So I don't need to ask anyone else for any other questions. We do special stains as well. We do somatostatin receptor staining as well. The machine that I have built here is quite good. The only time we might get a second opinion is if actually someone has something different. So there can be occasionally, like, for example, you can have a mixed pancreatic neuroendocrine cancer, which has a little bit of adenocarcinoma, a little bit of acinar. And just to confirm, we may send to some of our friends at, Mayo or Memorial Sloan Kettering or MD Anderson just to confirm, because the treatment pathway would be very different. But that's unusual. For regular neuroendocrine, almost we never send it out.
Would you recommend out in community, not practicing in a specialized center?
Right. Now, that's a different story. So if you want to get a second opinion on that, I highly support that, because we may do, a high volume center may do the stains a little bit differently and better, and they may do a different kind of a Ki-67 for you, and they may be able to differentiate between what is really poorly differentiated and what may be high grade, well differentiated. So there are some subtleties there that I think a second opinion is helpful at a high volume center.
Thank you. Dr. Mehr, any hypothesis why do certain patients respond to PRT and others don't? What could be the reason?
Um, well, the somatostatin receptor doesn't exist in isolation. It exists in a milieu or a soup of other chemicals, other hormones, other genetic factors. Um, Genetic stratification and genetic evaluation is important now, critically important in all portions of cancer care. So there may be and likely is a genetic component that relates to susceptibility. But having said all that, if the dotatate scan is positive, and the more positive it is, the better, the likelihood is that most patients will derive benefit from PRRT.
I agree. I think, yeah, very well said, Dr. Mehr. In fact, our lab, we are also looking at some of the mechanisms of radio resistance, and the pathways we are looking at are, is there a deregulation or downregulation of somatostatin receptors, or upregulation of certain enzymes like DNA PK, which repairs the DNA after the PRT DNA damage, as you nicely mentioned in your presentation. So we are looking into all those questions. Hopefully, that can help us devise new form of therapies to avoid this radiation resistance. Dr.
Right.
Liu, how often do you see lymph node swelling after surgery? Is it always pathological or could it be benign?
Oh, yeah, that's a good question. So we see lymph node swelling all the time, right? So you can have an appendectomy for appendicitis, and you can get some lymph node swelling. This is where the gallium dotatate PET CT and this new copper 64 scan is so critical, because it can differentiate that benign swelling versus non-benign swelling and tells you if there's tumor in there. But in theory, you should have had the scan beforehand so they could have removed those tumors and lymph nodes during your operation.
Fantastic. Dr. Liu, can I ask you a follow-up question? Can you advise or guide our neuroendocrine tumor patients about avoiding the 5 E's?
Okay. So the 5 E's, to be frankly honest with you, are kind of a little old-fashioned, antiquated thing. But here's what they are. The 5 E's are things that tend to trigger, and I use that in quote, trigger carcinoid syndrome. They include ethanol, exercise, emotion, epinephrine, and eating. I think it's eating. Did I say that? Yeah, eating.
Alcohol.
So, I said ethanol. Anyway, so here's the deal. So these are things that just trigger, that can be triggers for your carcinoid syndrome. None of them are dangerous. Okay, none of them are dangerous. So if you have a little drink, you might turn red. You know who turns red when you have a drink? Me. So I don't drink, so that makes me a cheap date. But when I go to Omaha, I make Sam Mayer buy me the biggest steak. Okay, so that's the important thing. So ethanol can make you flush more and be uncomfortable. Another, eating certain foods, that is for sure true. So just watch out for that. Again, not lethal. Exercise definitely does it too. So people can go exercise and they can develop some diarrhea and things like that. So watch out for that. Emotions are true too. So look, I mean, you have emotions. It is what it is. The epinephrine part of it actually is something I actually strongly disagree with. Back in the day, some of our older docs said if you received epinephrine, it would cause this. Therefore, a lot of our carcinoid patients think they have an allergy to epinephrine. The moment I see that, I strike it off their chart, because if you're dying and your anesthesiologist says you have an allergy to epinephrine and doesn't give it to you, guess what will happen? You will die. So I take that off. No one has really an allergy to epinephrine. It just makes you flush and makes your heart beat faster. Well, guess what happens when I give Dr. Chauhan epinephrine? It makes him flush, and it makes his heart beat faster, and it makes his blood pressure go up. So I would prefer to be the 4 E's.
Kind of like my wife, I say.
Agreed.
All right,
Dr. Chauhan?
Yes, sir.
It's Bob. It's great being able to beam in and out of these rooms. It's really fun. But I just want to let you know we have time for one more question. Then we're going to, I have a couple of announcements for the audience, and then we'll go on.
Fantastic. So I have only time for one more question. So I'll, ask you, Dr. Mehr, on a topic which is very close to my heart, theranostics. Where in your practice, where do you, sequence PRRT? Do you often use it as a second line or a third line? Have you ever used it up front after surgery, just to keep Dr. Liu happy after surgery?
Well, that's a fantastic question, because one of the sad facts of medicine today is we don't get to make all the decisions insofar as sequencing. Commonly, insurance companies help us make our sequencing decisions. And I see Dr. Liu is nodding his head. Most insurance providers now, in order to pay for PRRT, require that you fail or progress on octreotide or lanreotide. Okay. The question is, what does fail mean? So here's what I tell my patients. I tell my patients that for most individuals, neuroendocrine tumors are a very slow growing tumor. And when patients with neuroendocrine tumors get into trouble, they get into trouble for one of two reasons. As Dr. Liu said, either something's growing around a bowel that's going to cause it to obstruct, or they go into liver failure because so much of the tumor has replaced functioning liver tissue. So if I see a patient that's doing well on suppression, is not progressing, have normal liver function tests that relate to neuroendocrine tumors, and those are the ability to make albumin, bilirubin, and clotting factors, we can temporize. However, if a patient has liver disease that's progressing and is causing abnormalities in those specific liver function tests, or has developed a tumor that can cause bowel obstruction, that's an immediate indication in the case of bowel obstruction for surgery, or in the case of liver invasion, perhaps surgical removal of those sites, but you've got to have some normal liver left to function. Those are the red flags that go up to me and tell me it's time to really have a heart-to-heart about PRRT. Some people mistakenly think that PRRT can only be given for one 4-dose course. And if they believe that, then they'll save it until the patient gets to a point where nothing else will work. That's not a good idea. People need to understand that, like most cancer therapies, if a treatment modality has worked and then the patient needs it again, then we give it again. We do it with cytotoxic chemotherapy all the time. So first line, before suppression, probably not at this point with what we know. Given the other considerations, that's when we begin to act. Eric, do you have anything? Did I miss anything?
I would agree, but it's also a moving target. We're learning, so who knows? We'll find new things.
Great. Well, thank you so much, guys. With this, I would like to conclude our fantastic Q&A session. It was not only fun for me, but it was also enlightening, and I learned a lot. I'm sure our audience also learned and enjoyed this session. I thank again our superstar NET specialist, Dr. Mehr and Dr. Liu, and looking forward to doing this again in the near future. And thanks, Bob and Marianne, for having me here to moderate this session. I'd hand it over to you, and big round of applause for both of our stellar speakers.
Yes. Thank you, Dr. Chauhan, and of course, Dr. Mehr and Dr. Liu. We've done about 75 conferences, and this is our first virtual. wasn't really sure what to expect with this virtual platform, but I want to thank you. It was amazing this morning. I think it was very, very impressive. So let's do it again.